Welcome, everyone, to this first of a series of talks in nuclear cardiology. This is the first talk on SPECT perfusion imaging. I am Dr. R.F. Sheikh from the Icahn School of Medicine at Mount Sinai Hospital in New York. This talk will focus in on the basics of SPECT myocardial perfusion imaging, so that if you understand the fundamentals of this, you should be able to better grasp the other concepts and more advanced topics in nuclear cardiology. So when we talk about cardiac nuclear imaging in general as a modality in the context of nuclear medicine, and nuclear medicine itself has certain strengths. We like to look at large organs or field of view, such as whole body scans, VQ scans of the entire lungs, things like that. We also like to look at stationary objects like a liver spleen scan, thyroid, brain. These are things that essentially not going to move. But we're also looking for things that generally demonstrate increased uptake, such as in PET scanning or bone scanning. You're looking for, specifically in FDG and other tracers, you're looking for focal hotspots that would suggest sites of disease. But when you look at nuclear cardiology, it is almost the complete opposite of how nuclear medicine runs. So it goes on the other side of the spectrum. So we're looking at a relatively small organ compared to some, liver and spleen. We're looking at the heart. Now we're trying to do this in the current environment of trying to decrease radiation dose. And this organ also has relatively thin walls because we're trying to focus in on the myocardium itself. And within the myocardium, we're looking at areas of small pathology or areas of ischemia and infarct. So really, we're not even looking at the whole organ, but looking at parts of it to determine sites of pathology. This organ is not stationary. It's in constant motion because of cardiac motion inherently, as well as respiratory motion of the chest. And yet, whereas you would ordinarily like to spend more time imaging this, nuclear cardiology is trying to decrease the amount of imaging time. So again, another challenge. And this is defect imaging because ischemia or infarct will appear as defects rather than areas of focally increased uptake. And on top of that, we're trying to improve resolution and attenuation correction and other issues to try to sort out what may be defect artifactually. So really, we're taking the weakest portions of nuclear medicine and applying them into nuclear cardiology and to come up with a scan. So, one of the most technically difficult procedures to perform overall. But that being said, if you look at even modern modalities, you can see CT perfusion imaging here up on the upper left side, and as well as associated coronary CT angiography. You can see the ischemia, you can see the areas of stenosis, which correlates very well with the pathology that we see here on the catheterization. But when you look at this SPECT MPI, you immediately see where the areas of ischemia are compared to something like the CT, where you have to look a little bit more carefully. So very quickly you can identify, because of the great contrast offered by nuclear medicine, which is the strength of nuclear imaging. So it still remains a very much viable modality to use in detection of coronary disease. So when we're looking at the question of perfusion and myocardial perfusion scans, we're looking at coronary artery flow and myocardial perfusion. And we know that this correlates with stenosis, but it does not necessarily equal stenosis. And that's what we're really trying to ascertain, of whether any stenosis that we see, any significant stenosis, has a significant ischemia or not. So clinically, of course, we want to use it to diagnose and detect coronary artery disease. It's best done in those who have intermediate pretest likelihood of this disease. We also want to look at severity of patients with known coronary disease. That is sometimes done. Look at overall prognosis and see what's going on. Sometimes even look at efficacy of medical therapy. And of course, what's not listed here is determine intervention if it's needed, such as PTCA or CABG. And there are multiple myocardial perfusion agents that are used. This list is by no means complete, but we can see that there's thallium, there's technetium-based tracers, and then the bottom are the PET-based tracers. And there are different isotopes, have different energy levels, different half-lives that are used. But because of the radiopharmaceutical that they're attached to, they also have some different characteristics in terms of when they can be imaged, their washout and redistribution. So really, your protocol or procedure of how you're going to image the patient and stress the patient and when to inject is going to be determined partly by what tracer you are using in the lab, whether it's SPECT or PET. And like I said earlier, we're going to be pretty much sticking to SPECT during this talk. So it's also important to understand that these tracers have, as the myocardial blood flow increases, they really should have relatively linear uptake, as we can see from this top line here, because that helps us determine what the flow is, and if there's stenosis there, what the level of ischemia is. But we see in actual fact the fact that these various tracers actually have what's called a roll-off phenomenon, that as the myocardial blood flow increases, the efficacy of uptake rolls off. It keeps on climbing, but it doesn't do so in a linear fashion, and therefore you could potentially have decreased sensitivity of finding disease, certainly ischemic disease. But nevertheless, despite this, the tracers seem to do a fairly decent job. So one thing to understand about the tracers themselves are also what are their individual properties. Thallium, for example, acts like a potassium analog. It is required by the sodium-potassium ATP pump to enter cell, and therefore you really need a viable myocardium to have this functioning. There's a continuous exchange of thallium across the cell membrane once it's taken up. The myocardial extraction is pretty good at about 60%. And usually it's imaged after giving a single injection at stress, and then you can image it about 15 minutes after stress. And then you just kind of wait again for about 4 hours and you get delayed views, and that's when you get your rest image. On the other hand, the technetium-labeled compounds, and they're basically the only two of them left, sestimibine and tetraphosmin, these enter the myocytes passively and bind to intracellular membranes, in particular the mitochondria. Their myocardial extraction is actually much worse than thallium, as we can see over here, and they're imaged after 2 injections, one at time of rest and one given at the time of stress, and each one is imaged about half an hour to an hour, again depending on the individual lab's protocol. And we can see that when we stress patients, that whether it's exercise or pharmaceutical-based stressors or vasodilation, that the myocardial blood flow does increase significantly, specifically in the vasodilators such as adenosine and dipyridamole. So all that I've talked about, the roll-off and the extraction fraction, do come into play here in terms of being able to determine ischemia. But like I said earlier, these flow rates, despite all the limitations, we do tend to find ischemia for the most part fairly regularly. And when we are talking about the individual protocols themselves, for example, when we start with the exercise procedure, most commonly at the treadmill, there are actually various types of treadmill protocols as listed, and there are modified versions of those as well. The Bruce is the most commonly used. But in some cases, in Europe, in fact, stationary bicycle stress testing is actually used fairly frequently as well. So there are various types of exercise modalities. But then there are also targets where you want to feel, where you feel that there is adequate testing done. So for example, the most common used target is target heart rate, which is based on age, and the formula is listed. But there's also potentially you want to make the patient exercise at least until they fatigue, so long as they've achieved at least 6 METs of exercise on the treadmill. That is sometimes considered adequate. Another target is to use what's called the double product, or the heart rate and blood pressure product. And if you get into the appropriate range there or beyond, you may consider the patient to have been adequately stress tested. But in either case, in any of these cases, you inject the tracer at peak stress, and then you continue to exercise the patient as much as possible up to about 1 to 2 minutes after the injection. You allow them after that for recovery and patient stabilization. And you can image the patient within 5 to 10 minutes after they're fully stabilized and recovered, or as your tracer may be best indicated for its individual physiology. So aside from stress testing, there's the vasodilators as well. The older ones are like diaperdomol, where it's given infused over about a 4-minute period. And then a couple of minutes after the infusion, the tracer is injected into the patient, and that is considered the stress injection. With adenosine, there's a continuous infusion for about 6 minutes, and about 3 minutes, about halfway into the infusion, you inject your tracer, whether it's thallium or technetium-based tracers. And finally, dobutamine is also injected, is infused continuously, but this is incrementally increased to stimulate the heart rate. And again, once peak heart rate is reached as defined by the stress protocols, that is when the tracer is injected. The new pharmacologic protocols involve giving regadenoson. And when I mean new, regadenoson has been around for several years now, so it isn't that new. And in fact, many labs have switched over to regadenoson. It is an adenosine 2-alpha adenosine receptor, which is more specific for coronary vessels. This is given as a bolus administration of 10 seconds. So you deliver that, flush it, and really within a few seconds after that, you can give your SPECT tracer. And as far as the contraindications, it has similar contraindications as other vasodilators, but generally felt to have less severe symptoms. And it can be temporarily reversed by aminophylline like the other vasodilators because, again, it is an adenosine analog. But one thing to keep in mind is regadenoson itself has a very long half-life as opposed to something like adenosine, which has a very short half-life. So even though aminophylline may temporarily reverse some of the effects, the problem is the longer half-life of regadenoson could mean that those symptoms could come back. So you do have to monitor the patient just to be sure, and especially if they've developed symptoms. Nevertheless, there are other protocols where you combine exercise and vasodilator infusion. There's a low-level exercise that is done, and this is supposed to decrease symptoms and also actually improves imaging characteristics. But the problem is that this is contraindicated where both the vasodilator and exercise contraindications may be present. And in addition to that, it should be avoided in patients who've had a history of cerebrovascular accidents or other ischemic cerebrovascular disease. In terms of imaging protocols, I start with the technetium agents, and the technetium agents are pretty much used nowadays because with thallium, it's fallen out of favor. You start with a technetium with 2 injections, one at rest and one at stress. So you deliver a low-dose rest injection, image the patient, wait a bit, and then the patient undergoes high-dose stress with a technetium agent. And the advantage of this is that the stress images are the best images that are acquired because they're of the high activity that is administered. Another protocol is to do the stress first and then an optional rest, where you deliver the low-dose stress injection, and if that is abnormal, then you can give a higher dose at rest. Now, the issue with this is that the stress is lower dose. However, this is now increasingly used as a standard protocol because you can avoid giving the rest dose and therefore reducing the overall radiation exposure to the patient. So, especially in the intermediate likelihood patients where the image is fairly normal looking, you can avoid having to do a rest study. So another protocol is to use rest thallium and use technetium on the stress side. There are some advantages of using this because of faster and less time constraint. and some, you can get the best of both worlds. But the problem, like I said, is that thallium, one of the reasons thallium has fallen out of favor is because of the very high radiation exposure to the patient. So a combined protocol for this has really almost completely fallen out of favor precisely for that. And it's felt that the other information provided with technetium-based tracers is good enough. So once you've gotten all that, your information, you've done the stress testing, and you have all your images, you're sitting down to read the scan. How should you approach it? Well, you really should look at the raw image, something that's really underappreciated in reading cardiac nuclear imaging studies. First of all, it is highly recommended that you use a monochromatic scale. That means, and there are certain scales that are there in nuclear medicine, such as thermal, grayscale, invert grayscales, which are considered in the monochromatic category. And why you want to do this is because you really want to look for shadows, things, and look for breast or diaphragmatic attenuation. You might be able to pick out evidence of motion, look for any abdominal contents overlapping, anything that may be interfering with your potential for to read the scan accurately, and also look at the rest of the body for other medical signs that you may be able to pick up. So, for example, here's a scan that you can see. This is the raw images, the spinning images, where we can see that this patient actually has a photopenic area right under here, under the myocardium, and that's due to air in the stomach. Why that can be potentially significant is that air in the stomach will push up the diaphragm and therefore increase diaphragmatic attenuation. So again, you need to be aware of that before you go into the scans. But as also pointed out, if you look further down, you see a lot of attenuation here, photopenia here. It's not attenuation, actually, and it's due to polycystic kidney disease that this patient has. So you can pick up secondary signs of other medical conditions if you look carefully. Likewise, here's another patient where you can see there's a gap between the liver and the diaphragm here. There's a relative defect, photopenia here, and that's due to ascites. Again, ascites can push up the diaphragm and cause attenuation problems, inferior attenuation problems. And in this case, this is a scan that looks otherwise fairly normal. A patient's being evaluated for shortness of breath. But what we can see here is the LV looks fairly decent, but what's off is that you've got the really large-looking RV here. And again, this patient may not have ischemic disease, but may have other problems that may need to be evaluated. So once we've evaluated that, now we want to look at the actual, what we call splash images, the actual sliced SPECT images of the myocardium. You can evaluate it in the monochromatic scales or one of the other multicolor scales, but there are potential advantages of using one scale or the other. For example, a monochromatic scale might give you a better assessment of like LV thickness, LV cavity size, things like TID and artifacts, and look at the basic evaluation of fixed or reversible defects. Whereas the multicolor scale will accentuate defects and may help enhance the reading from monochromatic scales, but sometimes can lead to overreading of the defects, especially of size and severity. Now, the issue is that many people become familiar with one color scale and go with that, which is a very good idea. That's what you really should do, is get familiar with the scale and try to stick to it. But that being said, it is also recommended in the splash images that you should be familiar with at least one monochromatic, one multicolor scale, as being able to look at both may actually help enhance the accuracy of your read. Now, one of the important approaches in interpreting scans is that they have to make some sort of physiologic sense. For example, here's a patient with a mid-LAD stenosis. So you would expect that this should result of ischemia distal to the LAD and not in other vessels. And again, if you are seeing issues in other vessels, it may only be related to the LAD if there's some sort of aberrant coronary vascularity, or there's been some cabbage that has changed things around. So that is essential for interpretation because it helps you separate what may be real from artifact. Now, when you actually look at the SPECT image, this is actually a simplified view, but the images are displayed with the stress images at the top row, And the rest images at the second row, again, stress at the top, rest, stress, rest. And they're in 3 different axes. These are called the short axis, the vertical long axis, and the horizontal long axis. The short axis is slicing the LV right up the barrel of the myocardium. And it moves, and it's displayed left to right, moving from apex to base. So you're slicing right along the axis that is parallel to the LV. And in a vertical long axis, you're slicing the myocardium vertically. So in the short axis, you're looking at the anterior, inferior, septal, and lateral walls, whereas in the vertical long axis, you can see the anterior, inferior, and apical walls. The horizontal long axis moves from the inferior to the anterior wall, and here you get a better view of the septum, lateral, and apical regions. And this area, this scan is an example of an ischemic area in the infralateral wall, because you can see there's thinning of counts here in the infralateral regions, comparing the stress to rest, which are also corroborated, as we can see on the horizontal long axis in the inferior wall, lateral wall from stress to rest. This is a case of an infarct where we see more of a defect that does not change. It's a fixed defect because you're not going to have much viable myocardium in there, so that does not change, and therefore it is considered an infarct. But again, you have to keep your eyes aware that you see a fairly large RV, and this could be a sign that you have RV dilation or hypertrophy going on. So do keep that in mind when you're reading studies. So again, knowing about nuclear cardiology also goes into understanding what the patterns may be associated with that scan. For example, in men, we tend to see lower counts in the inferior wall. And usually that's associated with diaphragmatic attenuation. In women, there's a tendency to have defects more in the anterior wall. That's often associated with breast attenuation. In general, often the lateral wall may appear more intense than the septum, and that's because if you think about it, the lateral wall of the myocardium is closer to the rib cage, and the septum is more deep inside the rib cage, so there's more attenuation of the septum, leading to higher counts on the lateral wall. Likewise, you may have areas of the septum that have fixed areas and have decreased activity, and that may be due to the membranous septum seam in the basal regions, or potentially even RV insertion site. So, of course, be aware of those areas. Those are not ischemic or infarctive disease, but having to do with the natural anatomy of the myocardium. One aspect that we also, I mentioned and we look at is the transient ischemic dilation. And this is what appears to be an apparent dilation of ventricular cavity at stress compared to rest. This is really felt to be due to subendocardial ischemia. So you lose counts in the subendocardium, whereas the epicardial regions of the myocardial regions tend to maintain the activity. So it just looks like it got larger from stress to rest. And of course, what we really worry about in this situation is that we're looking at multivessel coronary ischemic disease. And of course, that has to be brought up. But keeping in mind that other things where you can get microvascular ischemia, subendocardial ischemia, such as hypertensive cardiomyopathy and microvascular ischemic disease, such as in diabetics, can all give you similar appearance without there being the presence of epicardial coronary vascular disease. So again, in the proper context, it may be appropriate to call TID as a result of these other diseases rather than multivessel coronary ischemic disease. And of course, this could also be artifactual from various issues in nuclear cardiac imaging. So here is a scan where you may be able to appreciate a little bit of cavity dilation from the rest distress, but you're also seeing this very dense interseptal wall defect that is present, that is consistent with infarct. But if you look carefully on the rest images, you can see just the small arms, a little nubbin extending a little bit further than we would ordinarily see in here in the stress image. So this would suggest that there is, and certainly in this area here, you see a very subtle area nubbin that's creeping forward. And this would suggest that there is low-grade ischemic disease present. So this would suggest that there is peri-infarct ischemia. So this is what we see in the multicolor scale. Now, if I just take this same image and all I do is don't change the intensity, don't change anything, and I just flip the scales to now show it to you in a monochromatic scale, you may be able to aesthetically appreciate how much the cavity looks more dilated here. And you can also see the ischemic disease better here, in fact. And so, again, aesthetically speaking, the monochromatic scale, again, to your eye, may be able to help you ascertain things that the multicolor scale might make you miss, or vice versa. Of course, as you become comfortable with the two scales, you will be able to better find them, but it may be a good idea to keep both of them in mind, especially if you're not a high volume reader. So just kind of flipping between these two scales, and you can see that how your perception of what you're seeing could potentially change between these two scales. And then we take the myocardium and try to make some sort of a semi-quantitative analysis. There are several models. This particular model displays a 20-segment model. We divide the myocardium into 20 roughly equal segments. There is also a 17-segment model, which perhaps in some sense is more popular. But all models try to aim for the same thing. And what they do is they break it down to segmental scoring, whereas 0 has normal uptake and 4 has absent uptake, and everything else is scales in between. And you take all the areas of abnormal uptake or abnormally decreased uptake, and you add those numbers up, and you on each of the stress study as well as the rest study, you come up with what's called a segmental stress score and a segmental rest score. And then you can take the difference between the segments as well, and you come up with what's called a segmental difference score. And in nuclear cardiology literature, each of these values has great prognostic implications, as well as assistance in being able to decide whether somebody should be move towards medical therapy or interventional therapy. So this is something to be aware of and may be helpful sometimes to convey to the clinicians if they are looking for guidance of how to manage the patient. When the images themselves are acquired for SPECT imaging, particularly for nuclear cardiology, they can be acquired in a static mode around the patient, specifically for rest studies. That is often done. But they can also be acquired in gated mode, which the EKG helps determine the gating. And the images are binned according to the EKG, so that various parts of the cardiac cycle are captured in each bin, and that happens around as the SPECT camera goes around the patient. And those bins are then individually reconstructed so that we know that each part of the cardiac cycle, what does the myocardium appear to do as far as motion is concerned. So when we are looking at these gate images, again, you can look at them in the multicolor scale, you can look at them in the monochromatic scale. Again, a suggestion might be that you might want to be able to look at both, because the multicolor scale will help you look at wall thickening better. It might help you pick up neighboring bowel issues or other culprits that may cause possible artifacts, whereas the monochromatic scale, again, help you examine boundaries better and wall motion, cavity size, that kind of things. But also possible in a lot of the nuclear cardiology software is to be able to volume render what we see, so that we can actually look at the images in the raw format of the actual SPECT things. These are these SPECT images acquired And if you contour them and limit them, this will not change the way these SPECT images look when you're reformatting them after they've already been processed. The surface program, on the other hand, is aesthetically pleasing because it kind of looks like an echo, or looks like a beating heart, but it's based on the manual contour. So if you don't contour things right, or if there's a bowel artifact that creeps in, this will change how the way things look. So for example, this is just an example of a gated study where the myocardium is, you can see the walls moving, but you can also see the thickening of the walls, individual walls, which show the relatively normal thickening that we see here, and relatively good wall motion. Cavity size is somewhat fine, but you don't really catch much of what's going on in the RV and other things. Now, again, if I were to just take the same image and switch the color scales, you will get a better assessment of cavity size. You may not get as good of an assessment of thickening, but you do get wall motion pretty well. But here you also get a glimpse of the RV. Although the RV is a little truncated out of here, you do get an assessment of RV motion, which can be helpful and probably a good idea for you to be able to report. So again, you could choose to use one of the two categories of scales exclusively, but again, it's important to know the differences and potentially use them where they might be helpful in certain situations. And this is just a volume rendering of the myocardium. And again, it looks aesthetically pleasing, but again, if artifacts creep in and we don't really contour that properly, this can look quite abnormal. So it's probably a better idea to be able to look at the raw SPECT images than rely on some sort of a surface rendering software. And again, putting all that information together, this is just a case where a patient has a dilated LV. We can see the chamber size is actually fairly large. It does not change between stress and rest. We also see that there's fairly irregular patchy uptake throughout the myocardium, going back to what I said earlier, that if a patient really has ischemic disease, it should make some sort of physiologic sense based on coronary anatomy. This doesn't. It's very patchy. And I've actually put a surface rendered image of the gated end diastolic and end systolic images just to make things simpler. And here we see that there really isn't much change between the end systolic and diastolic volumes, indicating that this patient has very poor LV ejection fraction. So putting this all together, this is actually a non-ischemic dilated cardiomyopathy. So it's not coronary disease related, but other myopathies. And gating can really, looking at gating images can really be of assistance, because sometimes you will get that inferior wall diaphragmatic artifact. You can see that there, on end diastolic view, there's what appears to be a photopenic defect. But on motion, that wall moves very well and it thickens very well, indicating that the myocardium is quite intact. And this is indeed an artifact. On the other end of the spectrum, here is a dense defect in diastolic views, but on end systole, that doesn't really move very much, and in fact does not thicken at all, indicating that this indeed is an infarct and not a diaphragmatic artifact. Similarly, you get some situations in breast attenuation where you can see there's a little bit of decreased counts in the anterior wall compared to the inferior apical regions, but on systole, those counts improve, and the walls move in very nicely together and symmetrically, which would indicate that this is again an artifact due to breast attenuation. And we do have to worry about pitfalls, as I mentioned at the beginning of the talk, that there are issues with the imaging. It's the most difficult nuclear procedure to actually go through with. And so you can end up with a lot of artifacts. This can be from motion, attenuation, or processing. But other physiologic things like left bundle branch block, especially if you do it on a stress associated with stress test, can give you physiologically false information. Hypertrophic cardiomyopathies can lead you the wrong ways. And again, other things like aortic stenosis is known to potentially give you ischemic looking picture, even though the patient doesn't have coronary disease. So in this situation is a patient that looks like they have a fixed inferior wall defect and potentially even slightly more prominent in the inferior wall at these in the stress view. So you might think that this may be an infarct or potentially infarct and ischemia. But this patient was imaged supine as ordinarily done. But if you take the same, this patient was turned over and imaged in the prone position, and we can see that inferior wall defect completely disappears at stress, indicating that is completely normal, and therefore that defect we see at rest is really more of a component of artifact. This is a study. If you look at it, it looks a little distorted. This is as a result of motion artifact on the patient. Now, if the motion artifact isn't severe or is appropriate, we may be able to use motion correction software to correct this stuff. But if but there are certain situations the motion is either too severe or in the wrong directions that we can't correct for that. So the patient really does need to be re-imaged. Here's a case where the patient did move, but not by much, but there was clearly motion on the scan. Nevertheless, the reconstructed image looked fairly normal. There was a little bit of an inferior wall defect, but that was felt to be really more diaphragmatic attenuation. And actually, when motion correction was applied to the scan, more defects showed up, and this is felt to be artifactual in this case. So again, you have to be careful even applying the corrective software, because the corrective software may sometimes actually lead you astray if you're not careful with it. Here's a case of, as I mentioned earlier, left bundle branch block. Is a patient who exercised, and we see that there's the thinning of counts in the septal regions. And the usual solution to this is to stress the patient with vasodilator-based imaging, which should not, in general, give you these defects. Here's a case of asymmetric septal hypertrophy. Now, when we ordinarily read the scans, our eyes tend to gravitate towards area that look decreased, because obviously we're looking for defects of ischemia or infarct. But we have to realize in this case what's going on is that there's actually increased counts in the septal region, and this is a result of asymmetric septal hypertrophy. And a giveaway of this will be that there should generally be a fixed defect between stress and rest, but also what you might find, for example, if you just happen to look at the EKG, you might see patterns of LVH on that. Moreover, the gating image might show some septal hypokinesis, and so the areas that you think are abnormal moving fine, it's the areas that seem normal that seem to be moving off, and again, that might be a clue that you're looking at asymmetric septal hypertrophy. And then gating itself can give you artifacts. For example, if you have severe atrial fibrillation with RVR, you may not be able to bin all the gated portions correctly, and the binning goes off. And as a result, the ejection fraction that you result looking at is abnormal. Usually it's quite low. And again, if it doesn't make sense with regards to the context of the patient, it may be as a result of the gating artifact. And finally, we have to keep in mind that there may be non-cardiac disease that we see. For example, here's a patient who had congenital pulmonary vascular surgery, and with resultant defect seen in the RV portion. This is not as a result of ischemia, but just as a result of post-surgical changes. So we do have to keep the patient's history in mind in order to know what may or may not be normal on a scan. So when we finally get all that information together, we're looking at the location, size, and severity of any of the ischemic or infarct defects that we're seeing, looking at the reversibility, and looking at TID and any other things we see, such as aneurysm, looking at the RV prominence, if we can see that. If you're using thallium, there's an aspect of heart-to-lung ratio. We don't need to go into that into the talk today. But finally, you're, of course, getting wall motion abnormalities and LV ejection fraction, all of which put together can be very useful for assessing the patient. So finally, to really do a nuclear cardiology scan well, you really have to have a thorough knowledge of pathophysiology, the tracer kinetics, and imaging procedures, as well as a working knowledge of disciplined approach to the study, a systematic method of scan interpretation, and understanding of normal variants and artifacts. And so if you stick to the basics, understand that you may be running into artifacts, and regularly look at the scan in terms of looking for both pathology and artifacts. It really should help you sort out a lot of the issues that we come across in reading nuclear cardiology studies. Thank you very much for your time.